Hello, East Coast, West Coast, and around the world. My name is Adrian, and on behalf of the ASMBS, the Bariatric Surgical Training Committee, and my co-moderators, I would like to welcome you to this edition of the Fellow Project Series. Joining me this morning is Dr. Kunoor Jain-Spangler, and the West Coast session will be hosted by Dr. Judy Chen and the chair of our committee, Dr. Matt Martin. Our goal is to bring the bariatric surgical education world together with high-quality didactics by content experts, and over the course of the academic year to cover all of the major topics within the ASMBS educational curriculum. Over the past 6 months, we've enjoyed a growing number of participants, and we welcome your questions to ensure an interactive learning experience for our fellows and for our faculty, and I believe we have over 500 for each of the sessions today with very few overlaps from what I understand. As a reminder, please use the Q&A function of the Zoom app to enter your name, your institution, and your question. We will get to as many of them as possible. And there will be a separate Q&A session for the East as well as for the West Coast rebroadcast this afternoon. Also, as a reminder, our next edition will take place on January the 8th. That's because the first Friday of that month will fall on the New Year's holiday. The speaker will be Dr. Phil Schauer, and he will discuss some of the most important evidence that every bariatric surgeon and every bariatric fellow should know about, where we have been, what we currently know, and most importantly, where we are going into the future. Today, however, we will hit upon one of the most important topics in metabolic and bariatric surgery. We will discuss the psychologic issues pertinent to the pre- and postoperative care of patients who undergo bariatric and metabolic surgery. If you have not yet realized the tremendous importance of this topic in the practice of bariatric surgery, you soon will. Here to help us today are two of the world's foremost experts on the subject. Dr. Gretchen Ames is a practicing psychologist as well as assistant professor at the Mayo Clinic College of Medicine in Florida. She will start us off with an overview of the psychologic workup and optimization ahead of bariatric procedures. Dr. Leslie Heinberg is professor in the Lerner College of Medicine and the vice chair of the Department of Psychology and Psychiatry at the Cleveland Clinic. She will discuss postoperative aspects as they relate to the bariatric patients. Ladies, thank you both for your service to ASMBS. Thank you for your expertise, and thank you for taking the time today. Dr. Ames, we will begin with your lecture. Welcome to the Fellow Series, and the virtual podium is yours.
All right, thank you for having me. It's an honor to be here and to present with my colleague, Dr. Heinberg. And I will go ahead and share my screen. All right, so we will begin with the psychology evaluation before surgery. Okay. So our team, just to give you some information about how we do things, the surgeon is the last stop in our process. So the patients, by the time they get to the surgeon, they have met the entire team. What I do want to draw your attention to is the concept of this bariatric board. And that is where we bring all of our difficult cases, and to emphasize everything that we do is a team decision. We all sit down together once a month and we talk about primary surgeries that we're concerned or have some concerns about. And then we bring every patient who desires a revision. And the latest data suggests that 15% of patients in surgeries done in the United States will be revision operations, and they all have different needs. Some have anatomical issues, some have behavioral issues, so we come together as a team to decide what is the correct course of treatment for that patient. So the learning objectives for this quick presentation, the purpose of the psychology evaluation, the components of it, what do we do, the content areas, what do we talk about with patients, and then if, I know some programs do it differently, the surgeon isn't the last stop, they're the first interaction. So I'll give you some clinical pearls about if you are that first point of contact, what do you want to be thinking about in terms of the psychology aspects of it, and what might you want to talk with a psychologist about this patient? I try to keep it light, and I use this slide in my group educations, and usually it makes people laugh. And what's interesting is when people come in and have a consultation with me, I think we've sat down together, talked, and we're having a lovely discussion, and then we get up to leave, and the patient says, "Did I pass? Did I pass the psychology evaluation?" Say, no, that's not what it's about. It's really to help you access a treatment of medical necessity that you need. And does the lifestyle change fit for you? You've made the decision that you want to have the surgery. So the next thing is, let's make sure that all the things that we're asking you to do in terms of lifestyle change will fit for you. And how can we optimize your outcome? What are your goals? What are your hopes in terms of weight loss and improving your health status? And how can we get you there? And many of you probably already know that the psychology evaluation is required by insurance companies. So patient misperceptions. I also put this picture up in my group education. And because our patients are bombarded with images that if you just work hard enough, you can lose 100 pounds and keep it off indefinitely, when in fact, for most patients, that isn't true. And what bothers me even more is the pejorative language around surgery. No surgery, no gimmicks. So leaving patients feeling like obesity is a choice, or it's my fault, or that it's a temporary condition. If I just work really hard, I won't have to deal with this anymore. The right way to lose weight is through diet and exercise. And then worst of all, surgery is cheating. If I have to have surgery, I'm cheating at weight loss. And we really have to kind of tune into those messages and help people understand it really is a treatment of medical necessity. And because our patients feel this way about themselves and have a lot of misconceptions about obesity, we need to be very careful with our language. And if you have not seen this article in Sword, it is fantastic. It was published in 2018 by Dr. Sogg and her colleagues. She talks about what language we should be using with our patients. And if you are using any of the words on the screen, what alternatives might you consider? And that, just the two in red, I won't go through all of them. I invite you today to consider never using the word obese again. Obese is an adjective that describes an identity. Obesity is a chronic medical condition. And failure. Our patients are very attuned into this idea that they haven't been successful with dieting. They already feel like a failure. So keep in mind, if you're seeing a patient for revision, try not to use that word at all. Less than optimal outcome. In other areas of medicine, we would never tell patients they've failed, that you have failed chemotherapy or that you have failed your joint replacement. So consider not using the word failure in your practice anymore. Components of the psychology evaluation. We have a number of screening measures that we use, and they are connected with our medical record system, so it makes it very easy. They are pushed out to the portal the night before, and when patients come in, they usually have it done. Sometimes they don't, and they will sit in the waiting room and use the iPad. And the screening measures are terrific because it really gives you a jumping off point of areas where you need to focus your energy in the clinical interview. And then we offer group education. And one of the really just unexpected gifts from this pandemic is that we now offer all of our classes through Zoom, and the patients love it. So I'm hoping that insurance companies will continue to do the right thing and reimburse for that. And then in the interview, I decide who needs individual treatment, either for eating behaviors or mood or some other issue that comes up. So screening measures, I won't go through all of them. I just wanted to show them on the screen. All of these are in the public domain, so they're free, and you can use them too. At bare minimum, eating behaviors, alcohol use, mood, and history of trauma. And having them come in with the questionnaire, you kind of already know how to sensitively ask questions if that's an issue. Screening measures are never meant for diagnosis. They are just to give you information about where to focus your energy. So the content of the interview, when you sit down with a patient, you certainly want to have a very good understanding of their weight history. This to me is so sad. Every week I will have someone come in and sit down, and the first thing they say to me is, I know you're not going to believe me. And I think, gosh, you know, what has this person been through? If that's the first thing that they say, I know you're not going to believe me that I don't eat that much, or that I have tried every diet there is to try. And I say, no, I absolutely do believe you. And then begin trying to listen with curiosity. All of our patients are there for the same treatment, which for their severe obesity, but they all have a different story about how they got there. So getting a timeline can be very, very helpful. I usually start with what their weight was in high school when they were 18 and go from there. Some people struggle from childhood, but what was your weight when you were 18? And when did you start gaining weight? When did this start becoming a struggle for you? And what were the events surrounding that? What's the most weight that you've ever lost in your life to get access to their dieting history? And is the weight that you are now, is this your heaviest weight? So you start to put together a picture, and all the while you are listening with empathy. I understand why you feel frustrated, that everything you've done up to this point feels like it hasn't worked. And now you're looking at a treatment that could really help you and change your life. So more content areas, eating behaviors. The numbers that you see in parentheses are prevalence data, and starting with binge eating disorder, this is with a rigorous structured diagnostic interview. About 10% of patients are going to meet criteria for binge eating disorder, which is eating a large amount of food, or what the patient perceives to be a large amount of food, and experiencing a sense of loss of control around that they can't stop what or how much they're eating. Or struggling with food addiction. Now, food addiction is not a DSM-5 diagnosis. It kind of takes the DSM substance use criteria and tries to apply it to food. This is an ongoing area of research, but about 14% of patients will identify with food addiction. Emotional eating issues. Do you eat for emotional comfort? Night eating, that is 50% of calories after the evening meal, or waking up from sleep and eating. And grazing is something that worries me a little bit. This is eating in an unplanned, unstructured way, kind of continuously throughout the day, and it's unrelated to cues of hunger and satiety. And that's going to be about 33% of patients. And this was actually a study that was done in Dr. Heinberg's group and looking at grazing behaviors. Then I also want to look at, does this person have a history of an eating disorder? It's rare, but it does come up sometimes. And where this worries me is after patients reach their maximum amount of weight loss, some of them become terrified of regaining weight. And if they have a history of an eating disorder, some of those old thoughts and behaviors can kind of creep back in. So that's a good thing to know, but it is pretty rare. I like to keep it simple for patients and their eating behaviors. This is a slide I show in our surgery education. And it's interesting because most eating issues can be summed up in these 5 things. And I will ask the group, you know, which 2 behaviors do you think the surgery is going to help you with the most, at least in the first year? And they always get it right, eating too much and eating too fast. So then we draw our attention to these 3 things. Well, the surgery isn't going to make you eat at the right times. It's not necessarily going to make you eat the best quality foods, and it's not going to stop you from eating for the wrong reasons. So if these are an issue for you, let's talk about that and figure out how we can help you. So clinical pearls, if you are the first point of contact, things to be thinking about. There's so much research on eating behaviors before surgery. Really, none of them have any prognostic significance for surgical outcome. In fact, most eating behaviors within the 1 to 2 years after the surgery improve pretty dramatically. What we have less good knowledge of is what happens between 2 and 10 years after that. And Dr. Heinberg probably presented on that. Things to pay attention to if people have eating issues before the surgery, and depending on the level of severity, they may have some mood disturbance that goes along with it. So in my follow-up care visits, I always have my consult note open so I can remind myself, okay, these are the areas that I need to talk about with the patient, particularly after those 1 to 2 years. More content, the psychosocial history. We don't have time to do all of these today, but those are in there. We'll just focus our energy on this side. Mood disorders, 44% of patients are going to have a lifetime prevalence of a mood disorder. Alcohol use disorder is pretty high, 33% of patients. So in our program, we ask patients to stop using no alcohol use at least 12 months after the surgery. We like them to remain abstinent, but we deal with the first 12 months first. And when you bring this up to a patient, you can get a pretty good idea about how they feel about it. Some people are very agreeable and others are like, oh gosh, I'm not sure about that. So drug abuse and dependence, 7.5%. Personality disorders, these are characterological problems, not symptom-based problems. So they are character excesses and deficits that may make you feel kind of uneasy about this person, or this person's kind of difficult. I don't know how well they're going to do, but they're not a reason to exclude. They don't have any prognostic significance either in terms of how people will do with the surgery. And the rest of these we will cover in the subsequent slides. So a little bit more on mood. Depression is going to be 39% of patients. And remember, there's some overlap with depression and physical symptoms. So that makes sense that this would be a fairly high percentage. Anxiety disorders, 32%. Bipolar disorder, there doesn't seem to be an increase in bipolar disorder with severe obesity. And the base rates for bipolar disorder are pretty low, less than 1% of people are going to have that. With mood issues, always asking about suicidal ideation or previous attempt, and then treatment history. Have they been in therapy? Are they on medication? So a third to a half of patients are going to be taking at least one mood medication, and they often stay on them. 4 to 5 years after surgery, they stay on them, so that's normal and it's okay. So pearls for mood issues. Schizophrenia, psychosis, dementia, obviously those are serious problems. It's so ironic. Yesterday, I just saw a patient first time in my 13 years at Mayo Clinic, a patient with schizophrenia, and he's 23 and 497 pounds. And his psychiatrist sent him to us. So the psychiatrist thinks it's a good idea. So I will be taking that person to our bariatric board for a discussion. The things that worry me are untreated severe depression, untreated bipolar disorder, and what often I find very helpful is asking the patient to get a letter of support from their psychiatrist, that the psychiatrist is on board with the surgery and that they are willing to manage the medications afterward, particularly with gastric bypass. We also recommend that they haven't had psychiatric hospitalization within the previous 12 months, and the same thing with substance use. Not that they can't have surgery, but see how they're doing at least 12 months after those treatments. And then, of course, active substance use is probably not the best time to be having bariatric surgery. Knowledge and expectations. When you sit down and talk with a person for an hour and then you have them in your group education, you get a pretty good understanding of what they know about the procedure they desire. I say this 1,000 times over. The surgery is a tool and not a cure. There is no cure for obesity right now, but the surgery is the best tool that we can offer to you. So let's make the most of that. The importance of lifestyle change. Does the lifestyle change connect with their values? In our patients, they are often trying to get to another operation. Maybe they need an organ transplant. Maybe they need a joint replacement. So these lifestyle changes absolutely do connect to their values because they're trying to cultivate a image for their future with better health and better quality of life. Where's their confidence that they're able to make these changes? And you know, the 3 to 4 months they spend preparing with us, usually confidence levels are quite high by the time they reach the surgery. And then setting the expectation for weight loss. In group, I actually have them calculate what their expected weight loss would be from the data, about 32% from gastric bypass, 25% for sleeve. And then we have a discussion around, well, is that okay? Is that an acceptable weight, a happy weight, a disappointed weight? Let's talk about that. And I do the same thing for BMI. I put this slide up in class and I say, you know, less than 2% of patients are going to reach a normal BMI after the surgery. Does that even matter? And it invites a wide range of discussions and opportunity for education. No, you don't have to have a normal BMI to be totally successful with your surgery and to achieve all the health improvements that you were hoping for. Chronic disease management, setting that expectation, again, tool, not cure, and the three important components of chronic disease management, certainly educating themselves about knowing everything there is to know about the surgery, self-monitoring. We know that self-monitoring is the best predictor of behavior change. Will people make that change? So we keep it simple in three areas. Please weigh yourself at least once a week, but really no more than once a day. Are you willing to keep a food journal, at the very least, keeping track of your protein intake the first little bit after surgery so that you don't come in with nutritional deficiency right out of the gate? And then activity monitoring. Are they willing to track their steps and their cardio if they are able to do any of that? And then follow-up care, again, setting that expectation. It's not just having surgery. You're going to see us at least 4 more times during the 12 months after your surgery. And we try to make it really easy, pre-scheduling appointments. We're working in video visits and trying to improve adherence in that way. Social support. When I sit down with a patient, I always ask them, who's in the house with you? Your immediate family. Do any of them struggle with their weight? Who does the cooking and the shopping? Where are you guys with convenience eating? Are you eating out a lot, getting takeout meals? If they're married, how is your partner's weight? And is your weight loss going to be an issue? The data suggests, it's really interesting, surgery is not a change agent. It's not going to make a bad marriage into a good one, and it's not going to make a good marriage into a bad one. But what may happen is that it will expose vulnerabilities where one person is out doing things they haven't done in a while, they're living their best life, they're meeting new people, and the other person is getting left behind. So we can decide, does there need to be some individual work around that going forward? And then lastly, we try to get our patients going, being more active immediately. I try not to exercise, was on that list. I try not to use the word exercise because our patients have all the same barriers we do. Weather, too hot, too cold, support, time, athletic ability. Some people are more athletic than others. The orange bubbles are an extra layer of complexity for our patients. Shame and stigma around body shape and size. They kind of feel hopeless. I don't even know where to get started because I hurt all the time. Or every exercise that I've ever, every physical activity I've done doesn't lead to weight loss. I don't know what to do or even where to start. We are so fortunate to have a physical therapist we send every patient to. They get started on a resistance training program that they can do at home right away. Bands, hand weights, and she also starts them on some form of cardio. Even if people in wheelchairs, what can you do? Let's focus on what you can do right now. And then also working on, we talk about this in group, what would you like to get back to doing? Let's set that expectation, help you cultivate an image in the future for what you would like to get back to doing. But more importantly, let's meet you where you are right now and see where we can go from there. All right, and Dr. Heinberg hit the eating behavior and all the rest of those things in her. I'm sorry that I missed it. I'll have to go back and read it or listen to it. And that's it. So thank you.
All right. Thanks, Dr. Dan, Dr. Jain-Spangler, ASMBS, for the opportunity to give this talk. Hear a little bit about the post-operative considerations. I want to start off just by saying most patients do well from a psychological perspective after surgery. Most patients note significant improvements in quality of life, in mood, in self-esteem, body image. But those aren't the patients that you're necessarily going to be talking to about their psychological issues. So I'm going to focus, unfortunately, on some of the areas of higher risk. For the sake of time, I'm ignoring a number of other really important areas, things like disordered eating, non-adherence, all of the factors that play a role in weight regain, all of the kind of social disruption factors that might play a role. And I'm going to focus on 4 areas that are fairly well studied, but also of significant concern. Psychiatric comorbidity, I'll be focusing mainly on depression, the very concerning data around increased suicide risk, and increased risk for problematic alcohol use as well as opioid use. So first I'm going to talk a bit about depression. So setting this up, and I think Dr. Ames is going to set this up, this is a psychiatrically vulnerable population. Patients who present for bariatric surgery have a much higher base rate of psychopathology compared to the general population. About a third have a current Axis 1 kind of psychiatric diagnosis, and almost 70% have had a lifetime psychiatric diagnosis. 20% of the patients we see also have a personality disorder or more characterological problems. And when we think about depression, depending on the study, between a quarter and 30% have meet the criteria for depression at the time of evaluation. About 9% of the patients we see have some ongoing suicidal ideation, and half at least have had that lifetime history. Another important issue is just how many of our patients are on psychotropic medications. About half are currently on those medications when we see them, but almost 3/4 have been on these medications across their lifetime. Well, so why is that important? We do know that the pharmacokinetics of these medications are altered with the surgeries that you all provide. And although we have the expectation that patients might get off of their diabetes medications, they may be able to get off of antihypertensives, most of our patients will still need to be on antidepressants, mood stabilizers, other psychiatric medications. And the data is suggesting that all these drugs that are tested and formulated for a normal stomach, a normal GI tract, just don't work in the same way. And when we kind of just look at the modeled dissolution of these drugs, some are increased after surgery, some are decreased, some are stable, but the majority are kind of similar to the sertraline graph that I show you, which indicates that patients are having reduced plasma concentrations after surgery, reduced area under the curve. So well-controlled psychiatric symptoms may not be so well-controlled after surgery, and clearly close monitoring is needed. When it comes to depression and weight loss outcomes, we also know that patients who have ongoing depression may not have as positive of outcomes as they do their peers that don't have that. And this has been shown in both Roux-en-Y gastric bypass and the sleeve. They still have significant weight loss. It's still highly efficacious, but just not as much as people who do not have depression. Weight loss also seems, at least early on, to potentially improve depression. But that seems to be within the first couple of years, and that benefit may not be lasting. This is some data from labs that just was recently published, which shows that many patients have those improvements, but around year 2 or 3, depression may be returning over time. So again, really pointing to the need for ongoing evaluation and potentially treatment. Next, we'll talk about suicide as well as other kind of suicidal or self-harm behaviors. Just to set the context, suicide rates have increased worldwide over the last several decades. All of this data does not include 2020, and concerningly, suicide rates are significantly up in the context of all of the stressors of the past year. When we look at the population, there are about 1.5 completed suicides per 10,000 individuals, and That's going to be an important number when we see what those rates are with our patient population. But for every mortality, there are a large number of attempts. We know what some of the risk factors are for suicide. And unfortunately, as I kind of go through that, if you look at the slide, a lot of these are things that we see in our patients, things like depression and anxiety, eating disorders, personality disorders, problems with substances, particularly alcohol. And then again, thinking of our patient population, chronic medical illness. Patients with chronic disease have a much higher rate of suicidal behavior compared to healthy adults. And indeed, our patient population is already at risk. There is a positive association between BMI and suicide, and a much greater prevalence of a past suicide attempt history. Some data from our group shows 73 times greater prevalence of past attempts compared to the population as a whole. Where this is really concerning is past attempts are the single strongest predictor for future suicide deaths. So our patients are already highly vulnerable when it comes to future events. And this is what we're seeing. This was probably the first well-controlled study done by Ted Adams out of Utah. And instead of just showing that they were at higher risk, they were matched patients. So patients were matched using their Utah driver's license on sex, BMI, and age, and found not just this increase, although that was not significant, 2.6 versus 0.9, but all non-disease causes. So those are things like drug overdoses, car accidents, other deaths that were much higher in our population. A much larger study came out of the SOS group that also was well controlled, that had 20,000 subjects followed for 20 years. And this was matching surgery patients with those who had had a lifestyle intervention. So they had the same sort of BMI, but had a different course in terms of their treatment. And again, those non-fatal self-harm, or that's really suicide attempts, or death by suicide was significantly greater. The odds ratio was 1.78. And then actual death by suicide was also greater in that bariatric population. And what they concluded is this is absolutely not a reason to discourage patients from bariatric surgery, but really indicates the need for those kinds of preoperative assessments as well as ongoing postoperative surveillance. When we put a number of these studies that have now come out together, there were first some early meta-analyses that were showing a suicide rate of 4.1, so much higher than that 1.5 in the general population. And out of all studies that were just looking at mortality, what bariatric surgery patients may die of, all-cause mortality was 1.8% of the population, but suicide mortality was 0.3, indicating that 1 out of 333 patients were dying a death from suicide. Again, very concerning. And then finally, the most recent meta-analyses just showing kind of graphically how consistent the data is when we look to the right above an odds ratio of 0. All of these studies showing that increased risk of suicide. The one on the right is showing the best control, matched control studies, again, much higher rate. And what they concluded is that patients who've had bariatric surgery have a 24 times higher rate of suicide deaths compared to the general population. So what they had found is instead of that 1.5 per 10,000, the suicide rate was 27 per 10,000. When you include suicide attempts, those kinds of self-harm, the rate was 170 per 10,000 patients. So this is very concerning data when we think of an untoward event that can happen post-surgically. So what's going on? As I tried to kind of note, the baseline population is just at greater risk. They've already demonstrated a higher rate of suicidal behaviors. But there may also be just an increase in distress if patients are disappointed in their outcomes, if they've regained weight, if their life didn't change in the way that they had hoped. There could be increased body image distress, social problems like divorce. There also could be some biological reasons, that some alterations in hormones or mediating peptides on the gut-brain axis might be playing a role. The altered kinetics of alcohol, which I'm going to speak to next. And then, as I mentioned, those altered kinetics of the pharmaceuticals that might be managing their psychiatric illness, if those are less effective, that again may put patients at greater risk. So what to do? Well, I think it's imperative that clinicians who are working in this population just appreciate that depression and suicide are real risks to those patients that we serve. And even if obesity improves, fully resolves, there is still that underlying psychopathology that should be treated. Obviously, ongoing monitoring, aggressive treatment are necessary to help prevent suicide. So let me move on to alcohol. We've known for quite some time that our patients postoperatively have susceptibility to alcohol. There's increased sensitivity and reduced tolerance. And when we just compare patients who've had a Roux-en-Y to patients who have the same BMI, those who are post-Roux-en-Y absorb alcohol much more rapidly. They have higher peak alcohol levels, and it takes them longer to return to that kind of baseline sobriety. This is probably the seminal study that is often referred to, that was done by Woodard. Brought patients into the laboratory, gave them a standard 5-ounce glass of red wine, and every 5 minutes measured their breath alcohol, breathalyzed the patients every 5 minutes. And they did that preoperatively, 3 months post-Roux-en-Y and 6 months post-Roux-en-Y, and found that at 6 months, the effect of that one glass of wine was 3.5 times more intoxicating. That red line that I put on my graph is a 0.08. So patients 6 months after that one glass of wine are legally drunk in every state, would be susceptible to getting a DUI. And I think many patients don't appreciate how intoxicated they become. And then, as you also see, that time until their blood alcohol or breath alcohol return to zero is significantly longer post-surgery. This is data that has come out of labs, which has been measuring patients for now kind of 7 years and looking at problematic alcohol and drug use. And on the left side are data from patients with Roux-en-Y versus the right, which is the band. And there is a significant increase in alcohol use disorders, alcohol-related harm, dependence symptoms, et cetera, as patients progress in the years after surgery. That dotted line is the population base rate of problems with alcohol use disorders. So early on, patients are very low on that. We kind of select patients who don't have those problems. But by the time we get to year 4, we're seeing a higher rate of alcohol use disorders in Roux-en-Y patients than the general population. That's not being seen in the banding patients. So again, what's going on? A somewhat controversial explanation is this notion of addiction transfer, so that patients go from food addiction to alcohol, but there's not particularly strong evidence for that. these new onset cases may not be so new. They may be relapses. Patients may not have been entirely forthcoming with their alcohol history. And although they weren't abusing alcohol at the time of surgery, they may have had those past problems. But I think a major factor are these altered kinetics of alcohol that are making the drug much more reinforcing, much more likely to cause dependence. And then finally, there may be just, when we think of brain and chemistry or reward circuitry, there could just be some shared vulnerability for factors related to both obesity, compulsive behaviors, and alcohol. So again, what do we do? This is a vulnerable population. They might be physiologically at risk. Interestingly, patients who've had a past history of substance use disorders who have achieved sobriety, those patients actually have better weight loss outcomes. And it may be those same skills that helped them achieve sobriety and make those lifestyle changes. Those skills are helpful post-operatively. But in terms of what to do, psychoeducation is very important. At the clinic, we have all patients who've had past difficulties or are kind of more regular social drinkers attend a one-time psychoeducational group to understand how alcohol will be experienced. Sometimes we have patients sign informed consents that they fully understand this risk, as well as behavioral contracts. And then finally, I'm going to turn to opioids and some of the concerns that are kind of coming out more recently around opioid use in our population. So there is a linear relationship, not surprisingly, between BMI and chronic pain. So when we think of class 3 obesity, the patients that we see, they have a 2.5 times greater rate of chronic pain compared to patients with a normal BMI. And there have now been 5 studies that have looked at opioid use following surgery, and all are showing this increased use, which is sort of counterintuitive. We would assume that as patients lose weight, their knees hurt less, their back hurts less, just like their diabetes medications. We would think that they would get off of these pain medications, and instead we're finding that they're increasing. So just a little bit of data. This is looking at patients who were either chronic users before surgery versus non, and the curves over the 3 years. So patients who had been using opioids, that's the top, they were increasing. They did not decline after surgery. They actually increased. But patients who were non-users also had an increase in opioid use after 3 years of surgery. Another study from this group, which was a retrospective cohort study across a number of health systems, looked specifically at those non-chronic opioid users and found that about 4% of patients become chronic users in the first post-operative year. So what are some of those factors that might put people at greater risk of becoming chronic opioid users? Some were just patients who were on non-narcotic analgesics, and it may be that they were well managed on NSAIDs and they can no longer take them, and so they had to switch. But also things like benzodiazepines, those patients were at greater risk. Patients who were smokers were at greater risk. And older patients were at less risk. And again, interestingly, thinking about how just this altered physiology, patients who had a band did not have that same risk as patients with a Roux-en-Y. And again, we can learn a lot from labs and their longitudinal data. This is the 7-year data, and found that early on, patients who were regular opioid users, that decreased from about 15 to 13%. But 7 years later, more than 20% of patients were using opioids. So again, what's going on? Well, we all know that opioids have addictive qualities. Patients develop tolerance over time, and so maybe they are just steadily increasing. But we would think again that they should be decreasing as their pain improves. There's also just like antidepressants, there is some altered absorption after surgery. And this is somewhat concerning in that after surgery, opioids have a much higher maximum concentration and a much lower time to reach that maximum concentration. And we think of, methadone versus heroin. Heroin is much more addictive because it enters the bloodstream very rapidly, much more likely to cause euphoria. And so some of these medications may have more of that experience after surgery just because of these kinetic changes. And then finally, there's some changes to the opioid receptor system after surgery. And that the opioid receptor availability is lower in patients with obesity compared to lean controls. But with weight loss, they have higher opioid receptor availability. So again, some of these things might also be playing a role. So what to do? We got to assess for problematic use preoperatively and really make sure that we are knowing which of our patients are at risk. Getting collateral information, I think, is very important. Checking those state databases, doing pain panels, urine tox screens. But again, preoperative education, having patients understand that this continues to be a risk after surgery. I think there's been a great benefit to some of these initiatives to decrease opioid use perioperatively. And certainly providers want to limit their prescription opioids to the lowest effective dose and for the shortest period of time. But just like with alcohol, we really relied quite a bit on contracts, treatment agreements, informed consent. But at these post-operative visits, not just at 1 month, but years later, it's something certainly to assess and monitor. So I'm going to just conclude with, although I shared a lot of bad news about things that can happen, bariatric surgery is still the most effective and durable treatment. And beyond just losing weight, most of our patients have improvements in many of the psychosocial domains, but there is this subset that might struggle and particularly struggle with things like depression, increased suicidality, substance use disorder. When it comes to my field, unfortunately, we have focused a lot on preoperative evaluation and preoperative optimization and preparation. But I hope that I've left you with the notion of how important postoperative evaluation, monitoring, assessment, and treatment is in the psychological domain as well. So I'm going to end there and thank you for your time. I'm looking forward to the Q&A.
I'm going to ask you, Leslie, can you talk a little bit about, from a preoperative standpoint, what do you see as the most important aspect for the workup of the bariatric patient from a psychological standpoint?
So that's like saying, which of your children do you love the best? It's hard to kind of pick that one area. Let me just kind of take a sort of a larger 30,000 foot step. Patients often think of that preoperative evaluation as a, thumbs up, thumbs down test. And we really are moving much more towards this notion of a psychological consultation versus an evaluation. And really thinking of our role is to optimize that patient and figure out on their journey to hopefully significant weight loss, significant improvement in their health. What are those potholes on that road that they could get stuck in? And so that could be psychiatric comorbidity, that could be substance use, that could be just problems with non-adherence. It can be quitting smoking. It could be a whole variety of things, lack of knowledge, lack of support, any of those things. But our goal is to help all of those patients get to the point of surgery and to hopefully just knock it out of the ballpark. We want them to be as successful as possible. So I think making that shift in the patient's mind really means that the entire program has to make that shift to think that this is not a test, this is not an evaluation, but this is an opportunity to really get a consultation from a behavioral health expert who is going to help you build on your strengths and address those weaknesses. I don't think I answered your question, even though I talked for a really long time, Adrian.
No, you absolutely did, and I think that just points out the complexity of the psychological evaluation, all the aspects that have to be taken into account. So we do have one question, but from my standpoint, the striking numbers, the 24 times higher risk of suicide in bariatric patients, that's something that I knew was higher, just didn't know it was that high. Is there a specific procedure? Are there any procedures that should be contraindicated to bariatric patients because of that point alone?
So as I noted, our patients are already vulnerable. They're vulnerable. They have a much higher rate of depression. They have a much higher rate of psychiatric illness, much higher rate of past suicide attempts. What is often disappointing for patients is that we want them to demonstrate some period of psychiatric stability prior to undergoing the stress of surgery. And for patients, they often think, oh, well, the reason I'm depressed is because of my obesity, or the reason that I feel so bad. And once I have this surgery, my depression's going to go away. My marriage is going to be fine. My kids are going to listen to me. My job won't be stressful. They have very, very unrealistic expectations. And it's very hard to hear that, no, we really want you to feel as emotionally strong as possible going into surgery. Just like a cardiac consult would want the patient's cardiac difficulties maybe not to be diminished, but to be as well controlled as possible. So that's really where we are often saying, patients need to have had at least a year without any suicidal ideation or attempts. That if they've been hospitalized, we want them to have had at least a year of ongoing treatment and staying out of the hospital. It's often hard for patients, but that increased period of stability is going to set them up to reduce that risk.
Well, Dr. Heinberg, I don't know if you have some powers of telepathy, but you actually answered one of the questions in the Q&A, which was how long do we need from a suicide attempt until consideration for surgery? And that kind of leads me to a question, since we haven't been able to do a lot of the pre-op, we're still trying to get Dr. Ames online. But as a surgeon, when I'm seeing, sometimes I see patients prior to our psychologist seeing them, and what are the red flags for you in the pre-op interview? Outside of alcohol, inability to quit smoking, what are some other red flags that we should be thinking of?
So one is, I would ask just from the surgeons to look at the medications. We see patients who are on a cocktail of 5 or 6 psychotropics. Those are patients who really often struggle after surgery. All of these medications are working differently. It's very hard to manage. If somebody gets worse, is it because their lithium isn't working the same way, or their sertraline, or they're antipsychotic, all of those things. So I would say that would be a simple thing for a surgeon, just to look at that medication list. Interestingly, I think patients can present very well to their surgeon, and not as well with a team who is spending a longer period of time. So they can kind of hold it together during that physical exam, but then in that hour-long or hour-and-a-half-long assessment with the psychologist, or those hours that they're spending with the dietitian, some of these these things come up. One thing, though, that probably does come up with the surgeon is these wildly unrealistic expectations. And when the surgeon says, well, we would expect you to lose more like 80 pounds, and they're saying, no, I have to get back to my high school weight, and I'm not going to be happy otherwise. And that would certainly be a red flag that we're setting somebody up to feel like they failed, even if they, succeed wildly in our view.
Sure. One other question regarding preoperative considerations. I know you are very well versed in patients who use marijuana beforehand, and we, I think, are still in the dark when it comes to how to handle that problem. So, you've done extensive reviews of the literature, you've researched this. What are some of your thoughts on the subject?
So it doesn't take long to do an extensive literature review because there's just not that many studies out there. I think what's really complicating this is that depending on where a patient lives, marijuana might be completely legal. It may be legal with medical marijuana, or it could be completely prohibited. And a lot of our programs, we also get patients from out of state. So, at least here in Cleveland, we have patients who come from West Virginia, Pennsylvania, Michigan, Indiana. All of those states have some different rules and regulations. So it makes it very, very complicated. There is some small literature which seems to indicate that although weight loss outcomes don't necessarily vary, there are some differences in terms of disordered eating after surgery in marijuana users. Not necessarily surprising for a drug that has munchies, for lack of a better clinical term, as a side effect. But also some data that perioperatively these patients may require more pain medication, more opioid pain medication. And then also just some of the challenges perioperatively from an anesthesia pulmonary aspect. So I think all of that really needs to be considered from the surgeon's perspective. And then just like alcohol, not all marijuana users can be kind of placed in the same bucket. So, there are patients who drink heavily every day. We would not consider them to have the same risk as somebody who has a glass of wine when they go out to dinner. There are patients who are smoking marijuana throughout the day, and that's really their way of coping with psychiatric symptoms. That's their way of escaping the stressors of life. We can't say that same patient is like somebody who goes to a party twice a month and smokes marijuana. So at least for us, we have different pathways. So somebody who is that occasional marijuana smoker, we just ask that they have one negative screen, kind of demonstrating that they've been able to quit for a month. But somebody who is a very heavy daily user, we may send them for some substance abuse treatment, and that they really need to achieve a much more prolonged period of sobriety.
Thank you so much, Dr. Ames. I did want to just bring up one question in the chat.
Sure.
Somebody wrote, thank you so much, Dr. Ames. As both a mental health provider doing these evaluations and a bariatric patient myself, I appreciate we are moving away from being gatekeepers, but rather providers who are looking for areas we can help with versus failing them. What have you found to be most helpful in those clients others might feel shouldn't have surgery, where instead treatment is most appropriate?
I'm not sure I completely understand the question.
What they're asking is if we identify patients who, from a psychologic standpoint, should not have surgery, how do we help them?
Oh, well, we actually never give up on anybody. We will have them come back. They can work on weight loss in other ways, lifestyle change, perhaps medication. we often have patients who, follow us for a period of time and then come back later when the surgery may be more appropriate. But we never tell anyone that they can't come back. We offer them whatever treatment they are willing to do, even if they aren't ready for surgery at that time.
Thank you. And the last question in the Q&A, do you believe there should be a psychological test prior to surgery or just the interview? If tests or questionnaires, what do you recommend? I know you did have a list there. And is there a standard?
There's not a standard. Like I said, I think screening on eating behaviors, mood, alcohol use, and childhood trauma would be the bare minimum. And again, those are all in public domain and free, so anybody can access those. I don't think usually that an interview is quite enough. The questionnaires give you a lot of valuable information and really do help you focus your energy in areas of more importance relative to others. So I don't recommend that, but I don't know if it's absolutely necessary. Leslie, you might have an opinion on that.
Yeah, sure. So we do psychological testing as well. We like to use, for example, for us, we use the MMPI 2RF because it has validity measures. That's just a way of showing if people are underreporting, overreporting. It's just a nice validity check because sometimes people present really well because they are seeing this as a test and whether they pass. And so knowing a bit more about personality, but also knowing, is this somebody who is trying to put their best foot forward, maybe with good intentions, but that there's something more to explore, I think is really helpful. Obviously, as we've moved to virtual and COVID, psychological testing has become more difficult, and we're relying a bit more on just those kinds of measures that people can do off of my chart, and we can kind of review them ahead of time.
Someone is asking, are you able to bill for the MMPI? We have not found a way. I would love to use it, but don't want to pass costs to patients directly in full.
Yeah, we absolutely bill it. We bill, not to get into the weeds, but we bill a CPT code for the electronic assessment itself, and then for a period of time for the provider's evaluation time. And I don't have the numbers of those CPTs like off the top of my head, but absolutely feel free to email me and I can share them.
Excellent. We'll go ahead and put your email in the chat for the person who is asking for it. I just want to say thank you so much to both of you. Someone did write, this is amazing. I'm a psychologist and this is the best presentation I've seen on these topics. So thank you both.
Oh, that's nice. Thank you.
All right. Hello, everyone. This is Matt Martin at Scripps Mercy San Diego, and here with my co-moderator, Dr. Judy Chen. Hi, Judy. And we're very fortunate to have both of our speakers, Dr. Ames and Dr. Heinberg, here with us. Please, if you have any questions, put them into the Q&A at the bottom of your screen, not the chat. And we will go ahead and go through some of these questions. And I'll take the privilege of asking the first question. So Dr. Ames, I noticed right from the beginning, you clearly differentiated primary bariatric surgery patients from those seeking a revisional procedure. And just wondering if you could comment a little more on that. Is that because of a higher incidence of behavioral health issues in the patients who need revisional surgery, or is that a part of why they, I won't use the word failed, didn't have an optimal result?
Yay. less than optimal outcome. Can you hear me okay? Because I'm on my phone.
Yes.
Okay. So we come together as a team, talk about every revision, because they often need a different pathway. That is, if patients are coming back to us because they have suffered a lot of weight regain through behavioral change or, life events, things that came up and they just really hadn't planned for and got out of the routine, maybe got out of their bariatric care and follow-up. And so that patient, we are going to set them on a track of lifestyle change, working with me, work with the dietitian first, and then possibly discuss a revisional surgery versus someone who's coming in with an anatomical problem where they do need surgical revision, or that a TOR, the transoral outlet reduction, would be a reasonable choice. We also have a lot of like transplant patients, solid organ transplant patients, where they start taking medications that cause a significant amount of weight regain after their surgery. So we'll take all of that into the bigger picture and help plan their treatment.
Okay. Judy, do you have any questions from the audience?
Yeah, let's start off with the first question. This could be answered by either Dr. Ames or Dr. Heinberg, but in regards to marijuana, is that part of the substances that are considered active substance use? And I know that for my practice, it is not.
Yeah, I think that's a great question. It's something that I have written a couple of reviews related to. This is a really hard question because depending on where you practice and depending on where your patients live, marijuana can be a drug of abuse. It can be a prescription drug. It can be, just a recreational activity. And so it's very hard to have sort of a universal recommendations. Also, just like with alcohol, we treat patients differently who use alcohol every day and use it throughout the day versus somebody who goes out to dinner and has a couple glasses of wine. So that patient who is smoking marijuana to manage their anxiety and they're pretty much high all day is going to be very different than the patient who went to a party a couple weekends ago and had some cannabis. We don't know a lot in terms of how this impacts patients. There's only a few studies. Doesn't seem to impact too much on weight loss or weight regain, which is somewhat surprising given that munchies are, for lack of a better clinical term, are a side effect of those medications. However, there does seem to be an increased susceptibility to eating disturbance after surgery for patients who are regular marijuana users. There seems to be some problematic or problems perioperatively with pain management. Patients who are marijuana users require more pain medications while they're in the hospital. And then there's a number of concerns just from kind of more pulmonology, anesthetic, anesthesiology component in managing that surgery. So I live in Ohio, which is a medical marijuana state. We do ask patients to provide proof that they actually have that prescription. We ask them to stop smoking any marijuana, to only use tinctures or edibles. So that though might be very different if you live in a state where this is an illegal drug.
Anything to add, Dr. Ames?
No, we have the same sort of protocol. If someone is taking medical marijuana and they have a prescription for it, we do the same, ask them not to smoke it. And our surgeons require at least 4 weeks of abstinence from marijuana use.
All right, moving on to our next question. Specific to how often is psych testing? So I'm not sure if that's the slide you showed, Dr. Ames, in the beginning, the many screening tests, or maybe something different. How often are those psych testing used for pre-surgical evaluation?
So for every patient who comes in to see me, they are sent, all those measures that you saw on my slide, those are sent out ahead of time to the patient through their portal. So we would love for those to be done when they come in for their consult, but that's not always the case. So we will have them an iPad. When they check in, the system will say you haven't completed your forms. And the forms that we use, like I said, they're all free and in the public domain, so they can be accessed by anyone. And the areas I think that are most important are eating behaviors, mood, alcohol use, and history of trauma, child neglect, sexual abuse, and physical abuse. And I know Dr. Heinberg, they also give some personality measures, but we do not give those.
Actually, I have a question in regards to if you do identify somebody who does have binge eating disorder. You know, it's a challenge in my practice to find help outside of our immediate practice. And so is there a duration of, you know, how long someone has to be in remission or their treatment? You know, again, I apologize if I'm saying them incorrectly, but that's what I've struggled with. Like when, what's the time period? I mean, you know, we know it for alcohol or suicide ideation, but for these others, like what is that interval that we define to be a successful way for patients to move forward?
So for us at the clinic, we do require treatment for patients who meet full criteria for binge eating disorder. We really think of these eating behaviors on a continuum, though. So we are not requiring them to have no symptoms and no concerns, but we want them to be falling into a much more mild range. I mean, ideally, that treatment helps for full cessation of binges, but we would want them to maybe no longer meet full criteria, only partial criteria, or go from severe symptoms to mild symptoms. You know, I think it's kind of similar when we see a patient with depression. Our assumption wouldn't be they have none, but that we at least kind of dialed it down. It's not as causing as much interference. It's just not as severe. Now, for other eating disorders, for like purging behaviors, for a patient who's bulimic, we do require a full 6 months without purging, just because of the kind of potential severity of the complications.
And let me ask you, what's your practice for patients who have had an actual suicide attempt? And I've had this a couple times now. Somebody's had a suicide attempt as recently as 2 months ago. And then they've seen a psychiatrist who said, oh, it was related to some acute life stressor. They're good on their meds now, and, you know, sent to us for bariatric surgery. You know, how should we be approaching those patients? And do you have a minimal time or requirements you set for those patients?
I'll go first. A suicide attempt within the past 12 months would be not an exclusion from surgery, but we would bring that patient into the practice and probably follow them at least monthly, monitoring depression, monitoring ability to make lifestyle changes, but we would probably stick pretty firmly to at least 12 months.
And we're a little bit different in also 12 months, but for us, we really defer entering the program until they've had 12 months of stability as confirmed by their treatment provider, largely just because we have found that they invest a lot of time and effort in having a number of visits, and then there's some kind of relapse, then they have to restart again. So, you know, for patients who have, you know, ongoing substance use or poorly controlled psychiatric illness, we sort of defer them until their providers say, okay, we've now had a full year.
We also offer, and you may too, your program too, Dr. Heinberg, medical weight loss. So we are set up for, if they are, you know, thinking that they are ready to make positive changes, then we will bring them in for that, but certainly not rush the surgery process.
In regards to post-operative follow-up, I think there's a question that's kind of looking into what, for either of you, what's your routine schedule? And then for me to add on, you know, is it tailored potentially to, you know, certain diagnoses? It sounds like, Dr. Chavez, pediatric obesity psychologist, and she does a 9-month post-op evaluation. And so it sounds like, in addition to those questions, how do you get the follow-up too, right? How do we get them to come back in?
I'll go first. Our follow-up schedule is 1 month. They will finish up with the surgeon. They'll be released by the surgeon. Then they come back to see us at 3 months, 6 months, and 12 months. It's a medical visit, it's a nutrition visit, it's a psychology visit, and we pre-schedule those. So it pops up in their portal, whether they want it to or not. And we are working really hard on trying to incorporate video visits and connecting our medical center with other labs in the community. So patients can go out and have their labs, and they already connect to our medical record system so that we can start working on improving adherence to people coming in the first year after.
Yeah. Ours is very similar. We see everybody at 1, 3, and 12 months. The 1 and 3 is scheduled when they're getting all of their, preoperative visits, postoperative visits. Before this year, we linked those so that they would be seeing, say, nutrition, psychology, and the surgeon all on the same day. And 90+% of patients were coming to those visits. Now that they are virtual visits, it's a lot easier, unfortunately, for patients to just say, oh, I'll just see that surgeon so I can get cleared to go back to work. And they're not making those other appointments, which is, I think, unfortunate, across the board, no matter what discipline. Follow up and drop out after surgery is just, I think, so problematic for all of us.
Wow, those are multiple appointments actually. So you guys must do a lot of work, or maybe have clones.
No, I should add that we call these at the clinic spa visits, which are called shared psychological appointments. People are always up when you say, oh, you have a spa visit at 9:30, who doesn't want to go to that? But so we do them, and it's like a shared medical appointment. So we're seeing a group, and they actually support one another because it normalizes a lot of what they're going through when it's everybody else who had surgery 1 month ago or 3 months ago. Oftentimes, I think that is a really valuable piece of it.
Oh, I love that. That's great. There's a question in regards to alcohol. I know that Dr. Ames, you mentioned 12 months of no alcohol. The question specifically is, what's often the amount allowed? And I guess also to piggyback on that, in regards to other things, when you talk about consenting about the risk after surgery, and this is not particularly related just to alcohol, maybe suicide ideation, who does that consent? Is it the surgeon? Is it you? When do you do it? At the same time of the procedure? So lots of questions in that one, but I wanted to try and respect everyone's time and wrap a couple of questions into one.
I'll answer real quickly about the consent piece. So it's usually the behavioral health provider, the psychologist. And, obviously, if they don't follow this, we're not going to send the surgeon back to undo their gastric bypass, whether it's a contract or a consent. But I think it just communicates how serious we are, how concerned we are. And I also just think for a liability purpose, it is helpful because patients can come back and say, well, nobody ever told me that this was a risk. So, before I write my letter saying that they're ready for surgery, sending that off to the insurance company, I will have them go through that contract or consent, and then that's added to the electronic health record.
Well, and Leslie, let me ask you, do you guys ask your patients to try to remain abstinent at least 12 months after the surgery?
We recommend we recommend that you never drink alcohol, but realistically,
people rebel against that.
We say you should not drink in the first 3 months after surgery. This could cause lots of complications. The best thing to mitigate your risk is to avoid alcohol. However, if you were to drink, absolutely drink in extreme moderation and never ever drive afterwards.
Yes. Did that answer all those questions, Judy?
I believe so. Just to go through the Q&A, yes, I think specifically it was post-op, but I remember you mentioned even pre-op, you tell them not to drink alcohol for 12 months. Is that correct?
No, so a post-op.
Okay, I apologize.
So pre-op, we do encourage them. The person that I worry about is the one who enjoys cocktail hour every day, right? That's a part of their social life. Maybe that's what they do with their spouse at home. So we recommend that they start cutting down right away and see how that goes. And by the time they get to the surgery, we say, if you can, we're not super rigid about it, but if you can, try to commit to no alcohol use at least 12 months after. And then we can reevaluate at that point.
Perfect. There are so many questions because I think this is such an important topic, but I do want to respect time. And so, you know, I think in regards to the majority of what people were trying to ask, I think we did at least cover some of it. I truly apologize for any of those that did not get their specific question answered or things like that. And so I definitely wanted to share that I really appreciate this talk. I just continue to find it to be so incredibly helpful, helps me to remember, even though we're in this field every day, it's just so important to have that patient first language. You know, I think that we're ultimately really trying to help patients and that motivational portion and things. So thank you, Dr. Ames, Dr. Heinberg. And I think, I hope everyone enjoys the rest of their weekend. And this video is archived and available through ASMBS, and we're always happy to try to get, if there's any other pressing questions, you can reach out to Dr. Dan. Is there a place for follow-up at all? I can't recall, but we can always address that in the future.
Right now there isn't, Judy, but that's an excellent idea. And we should have some kind of dialogue box that maybe we can get started where people can add questions that they think of. And it would also give us a great ability to determine future topics that should be covered. So excellent point and idea. Thank you.
We're constantly improving and evolving.
I'm sorry, I was going to say, we don't mind if anyone who did not get their question answered, they can reach out to us over email. I'm happy to answer individual questions.
Thank you for volunteering. Someone actually requested your email, but I did not want to volunteer.
Yep, it's on my slides too. I don't know if they get a copy of the slides or not.
It's recorded, so anyone here can absolutely go to the recorded session and see if you had that available. If your email's out, that's another wonderful way to reach out to you.
Great. Yep.
All right. Have a wonderful weekend. Stay safe. Happy holidays.
Thank you.
Thank you. Had fun.
Bye.